to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have, and will follow up on questions he does not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Dr. Eric Flyckt is Director of Client Analytics for Objective Health. Eric leads Objective Health's Client Analytic team, which is responsible for delivering products in the Objective Solutions and Objective Answers catalog. He is passionate about the application of data in improving the quality and efficiency of healthcare delivery. Prior to joining Objective Health, Eric spent 6 years as a consultant with McKinsey, serving clients across the healthcare spectrum in North America and Europe. His clients included large health systems and academic medical systems, as well as companies in the pharmaceutical, medical device, and health insurance industries. He is focused on projects relating to strategy and clinical operations. Eric holds an MD from Stanford University School of Medicine with research interests in neuroscience. He received a BS in Biological and Cognitive Sciences and a BSBA in Finance and Marketing from the University of Denver, where he graduated Phi Beta Kappa. It is now my pleasure to turn the floor over to Dr. Flyckt to begin today's presentation.
Thank you so much for that introduction. And welcome everyone to the session. I want to talk a little bit today about some of the pressures that healthcare industry is facing and hospitals are going to be facing over the next few years, and particularly the strategies that hospitals should be using to address these challenges. There's a lot of focus on new models and partnerships to pursue, but there's some of the very basics of running a hospital that obviously have to be in place for that to be effective. And that's where the term positive Medicare margins, which has sort of become an industry mantra, has come into vogue and has become shorthand for hospitals' viability over the next 10 years. There's still significant value locked up in traditional operating margins levers. And the question really for hospitals today is, where are the biggest opportunities for me? Where should I be focusing my attention? And where should I be investing my time and effort in order to see the biggest impact? Ultimately, every hospital needs to develop a balanced portfolio of initiatives, essentially a strategy to meet the projected financial targets, both within margins, but also looking beyond margins to strategic growth initiatives and some of the emerging integrated models that we'll cover a little bit today as well. So with that, let me jump ahead to page 3. So the first area I want to spend a few minutes talking about is some of the great pressures and the uncertainty that the industry faces. This is obviously not news to, I'm sure, most people on the phone, but in short, the future is going to bring more patients, but each hospital will be paid less for those visits, and each visit will cost you more. So volumes are going up, really driven by population growth, demographic shifts with older and sicker patients coming on board, and coverage expansion driven by healthcare reform. At the same time, prices are continuing to be depressed. Reimbursement pressures are continuing both in the public and commercial spaces. Coverage shifts are expected from Medicaid, from commercial plans to Medicaid and to the exchanges, and there's going to be an increase in the amount of risk sharing. We're already seeing this coming on board at this point with payments for bundles, episodes, or for capitation. And really, Medicare margins as a shorthand for performance comes in is in large part driven by this. The belief that margins are going to go down to Medicaid levels, and that therefore, if I can survive at that level, then as a hospital, we're going to be fine. I think the belief is that it's not going to quite come to that, but the pricing pressure will nevertheless be there. The final piece of this is costs. Medical inflation and technology advancements have been a driver of medical cost increases over several decades, and it's continuing on even today. At the same time, there's additional pressure from compliance issues and IT infrastructure, for example, as well as property, plant, and equipment infrastructure investments required to meet the increasing volumes. Thirdly, we have physician employment and practice management, which is becoming more prevalent as well, with more and more hospitals or systems taking on employment for physicians, which is increasing cost center. So all of these together add up to quite a challenge. And if you turn to the next question, I think the question for hospitals today is, well, which of these factors is going to be important for me, and what's the net result? On page 4, I'd like to take a poll of the folks on the line and just ask which of the following, A through E, would you expect to have the biggest impact on revenue over the next 10 years at your hospital? Options are population growth, demographic shifts, coverage expansion, coverage shifts, or reimbursement pressure. And I'll pause for a few moments here to allow people to answer the question. So if anyone's joining a few minutes late, we're currently doing a poll, so if you'd like to participate, you can see the question on the screen. All right, I think we can go ahead and close the poll. So that's right, reimbursement pressures comes out top, and that's very much the right picture. Population growth, demographic shifts, and coverage expansions end up having a roughly similar effect. Coverage shifts are much, much smaller, but reimbursement pressures are about twice the size of any of the individual ones listed above. So that's exactly right. So I'd like to spend just a few moments, if we turn to the next slide, covering some of these trends in a little bit more detail. So obviously, volume is expected to climb as population grows and boomers age. You've got a 0.9% per annum growth rate for U.S. population, which gets us to about 360 by 2025. Hospital admissions, though, are likely to grow much faster than that, because of the aging boomer population. On the next page, page 6, you actually have to add to that the increasing burden of chronic disease that we're expecting. We're seeing many, many more patients that have one or more chronic diseases, and the number of patients with chronic diseases is expected to increase 10% over the next 10 years and 20% by 2030. This means that the cost per case is going to increase, as well as potentially driving additional admissions beyond what we saw in the previous slide. So switching gears to the reimbursement picture now, let's turn to page 7. Reimbursement pressure, as you all correctly identified, is really the biggest driver of profitability or revenue over the next several years. The projected Medicare reimbursement rates highlighted as potentially a 2% cut, would have a significant impact on Medicare reimbursement rates over time, dropping price by 13% by 2019, which is the end of the projection phase that we typically look at. That's significant. In addition to Medicare going down, obviously there's the potential for other forms of reimbursement shifting down as well, so that commercial rates start growing at decreasing rates, and that's something that we expect to happen. If you look to page 8, another major or important factor that's getting a lot of press is the commercial lives moving from Medicaid to the exchanges. Essentially, we have 6 million lives moving from the smaller individual plans to Medicaid, which represents a significant cut in reimbursement rates. We also have 6 million lives moving from large group and ASO to the exchanges, which has the potential to be to reduce reimbursement rates as well, although much less so than for the Medicaid rate patients. The other key to this slide, though, looking at the left and following those arrows around, is that there's a huge, this is very much offset by the 20 million uninsured that are over 20 million uninsured that are expected to get coverage over the next few years. And net, this shift is quite positive for hospitals. Shifting gears again and talking about costs, this is page 9. The trends on page 9 basically show how technology has driven costs over time. So in imaging, you've moved from X-rays to CTs to high-tech CTs with functional imaging or PET. In surgery, you've gone from open cases to laparoscopic cases to now robotic cases. In angioplasty, you've gone from balloon catheters to stents to drug-eluting stents. And at each stage, you've seen a significant increase in the costs associated with these technologies. And while some of these technologies listed on the far right have been around for a while, the trend doesn't really seem to be slowing all that much. And we can expect these price increases or cost increases to be driven both by imaging, devices, implantables, and drugs over the foreseeable future. So turning to the next page, with all of these trends affecting the industry, it's very important that a hospital understands and evaluates just what these trends are going to do to its particular situation. What's the financial gap that they're going to create? And therefore, what's the burning platform for change, if there is one? The factors are, some of these factors have very local effects depending on who your patient population is, what the demographic shifts are going to be at your local level, and what the payer types are within a local level. So that means that there are hospitals for whom these changes are highly negative. There's many hospitals that basically break even on the effects of these various trends. And there are actually some hospitals that do quite well from the net impact of all of these, especially driven by its reform. That means that in order to plan for the future, a hospital really has to have a good sense of how each of these things are functioning. The other thing to call attention to here is that I've seen some hospitals basically make the assumption that all rates go to Medicare. And while your analysis doesn't have to be precise, it does have to be within the ballpark and should inspire confidence. And the Medicare scenario, all rates going to Medicare scenario, is so extreme that it, I think, fails that second test. I think it doesn't put you in the ballpark, and it creates an alarmist platform that may be too, and paint a picture of a gap that's too great to fill. The example of reform or forecasting that's shown on this page shows a picture that's pretty typical. The operating revenue side of things tends, for many places, will continue to grow, but the net income may very well decline. And in this case, we go from a hospital that is hoping to have a margin target of 5% and ends up by 2019 having a gap of negative 4.3%, which means that they need to find $60 million in order to close that gap. The ability to point to a number like that is very effective in scaling the effort that you put in place and helps set the foundation for your hospital making real changes in the operations and strategy. So that brings us to the close of the first section. The second section, beginning on page 12, now lays out some core concepts on how to survive and thrive in this new environment. The heart of this is there's a set of core models that every hospital and clinic needs to focus on, and then there's sort of new or expanded models that get into integrating systems, so to provide either economies of scale or to support new capabilities in population health. On the core model side, it's really about how efficiently and how effectively am I providing care at the encounter level within my hospital and clinics. Those are your operating margin levers. Secondly, it's about how do I, in the markets where I am, target those sub-geographies, those specific service lines, those patient segments that are going to be the most profitable for me. So it's about not growing overall, but growing in a very specific area and set of areas, potentially in different ways than you're growing today. The population health on the bottom right is really all about taking on risk, which is coming, and being prepared with the skills and the range of partnerships to do so effectively. So it means partnering with payers, with employers, and physicians. And really, for the long term, this is an essential component to being successful. Economies of scale is an interesting one, and I think one that is more optional, say, than the others. This is all about getting partnership or mergers in place so that you can start leveraging the scale, the skill, and the resources of a larger system to win. There are, it doesn't seem to me that the independent hospital is going away, but there will be more and more systems that are rolling up like this, and there are opportunities to partner with larger systems, or there are there are going to be larger systems that try to build further scale. So that's something to expect in the market. If we return to page 13. I just wanted to expand on this a little bit and talk about sort of where the basic piece of this lies. And operating margins is really at the cornerstone, the keystone of any of this. Essentially, if you have lower cost per encounter, it allows you to develop targeted growth and be profitable in specific areas. If you have lower cost per encounter, it allows you to succeed in population health, because at that point you're trying to lower volume of encounters and thereby lower total cost of care, which is important to drive which allows you to drive your profitability under a population health scenario. Similarly, economies of scale, it really only makes sense to roll out systems if they're going to be successful. So all of this points to operating margins being the primary focus for the near term. If you don't get this right, you're not going to survive. And that's if we turn to page 14. The centrality of operating margins in this framework, as well as the fear about rates going down across the board to Medicare margins, has driven the industry mantra of getting to prospering a government reimbursement rate. And essentially that means that a near-term focus on operating margins is essential. If we switch gears now and turn to page 16, we're going to talk a little bit about those operating margins in more detail. As you look at these, what's interesting is that many of these have been around for a long time. These are not new levers. You're really asking some very fundamental questions about your hospital or your system. First is, how well are you collecting on the revenues that you've earned? Second is, how efficiently and effectively are you running your facilities, which is all about clinical and administrative operations, about labor productivity, it's about materials management. And thirdly, it's about how engaged and efficient and effective are your physicians in delivering the care, which is managing clinical variation both on the cost and the quality side. I'm going to run through each of these briefly, and I'll tee up the question now and we'll repeat it in a few moments, but which of these areas do you think delivers the most value typically to a hospital? Where is most potential stored up? So turning to page 17, revenue cycle management is, I start there because this is essentially collecting on what you've already earned. And it's a margins lever because despite being a, with revenue in the title, this is all about driving collections to the bottom line. It's received a lot of attention over the last 5 to 10 years, and it's only going to become more important as co-pays, deductibles, and balance after insurance increase over time as plans evolve and patients choose to be more at risk themselves. Things that were once innovative are becoming increasingly standard across the industry, and you see a lot of outsourcing or management service of revenue cycle in the industry, serving hospitals. And a lot of these can be very effective. The interesting thing is, despite the focus in recent years, there's still a lot of opportunity that we see at our clients in this area, distributed across the different levers that you see on the left there. If we turn to the next slide. Operations, unlike revenue cycle, which is a relatively new area of focus, operations is something that's been around as long as hospitals have been around. It's received a lot of attention over the last 2 decades, and Virginia Mason Medical Center, and it's probably one of the earliest to bring lean principles to hospitals. The interesting thing is after all this effort and time, most operational efforts fail. I think we have internal analyses that suggest that something like 60–70% of efforts are not effective. And this is really driven by, it's easy to identify issues. However, focusing and making sure that you're addressing the right ones can be a bit of a challenge. More to the point, implementing and sustaining the impact is very, very difficult. The way that I've seen successful systems do address operations, and there's many variants of this model that exist, is to focus not just on the operation system itself, but to also focus significantly on the management infrastructure and the mindsets and behaviors of the culture of the institution to support operational change. So that means tracking your performance regularly and having that data available to the people that manage frontline processes. It also means making sure that leadership, staff, frontline personnel all understand, bought into the principles, and think that it's important to know how to act and behave differently, and are rewarded when they act in the right way. And that cultural component is probably the most essential and the biggest source of failure within operations. Turning to the next slide. Labor and productivity labor is a hospital's largest cost center, and it gets a lot of attention. Obviously, it's about much more than FTE volume. It's not about just hiring and firing. It's about how you employ overtime. It's about how you employ skill mix. And very importantly, in supporting the cultural point we made on the last page, it's about managing your turnover and developing your staff as managers and as leaders within the organization. There's an issue here because external benchmarks exist, but they tend to be difficult to apply. And there's a lot of them around, but any particular hospital finds it very easy to say how they're different and how they're distinct from whatever benchmark it is that's provided. You can always point to a floor and talk about how the the patient mix or the flow processes are different or the loads are different, and therefore it's not quite it's never quite fair to use an external benchmark. For that reason, internal benchmarks are becoming more and more common. So looking essentially at your own practices over time, identifying when you're working well, and trying to identify what allowed you to work well in highly efficient periods. I think there's also often a hesitancy to address staffing issues. It's a difficult and thorny area, and especially hospitals with community missions find it something that they're a little bit less likely to go after than others. So we've seen some very large overstaffed hospitals that essentially have been driven by an unwillingness to address the issue. Not surprisingly, for all these reasons, there are significant opportunities that exist here. Although from site to site they tend to be very variable. Turning to page 20. Materials management is often the second major cost center in a hospital. The interesting thing here is it's a discrete area, and it's actually quite highly functioning. There are often experienced leaders and teams on the ground, established processes, and there's strong partners available throughout the delivery chain in terms of purchasing organizations and distributors that can help the hospital be efficient in this space. I'd say in this area there's typically pockets of opportunity focused in one or two areas rather than opportunities across the board. Really the next frontier here is closer management of clinical choices and decisions, which is something that's already quite established in formulary management, is emerging in areas like drug substitutions, and is expanding into device choices as well. And in these new areas, success is really very dependent on working with clinicians, pharmacists, and physicians in a way that that many did not do 5 years ago, 10 years ago. Page 21. Clinical variation is really the next frontier for many systems. And this is for a couple of reasons. The hospital-physician relationship has been evolving over some time, but it's gone from a place where physicians choose to bring their patients to, often selecting multiple hospitals, to more and more of a single choice, a single area that you want to practice. With more and more physicians employed and more cost pressures, this is an area that now people are getting into. I say now, it's probably been 10 years that people have been focused on this, but I think the efforts have been far more nascent, and even today the level of comfort among administrators and physicians in tackling these issues together is not there. You really do need mutual trust and a physician base that's highly engaged. You need to be able to communicate to physicians a significant case for change, and provide them with the training and the resources to manage their own costs successfully. You need to ensure that physicians really can lead this and develop clear objectives, targets, and metrics, as well as provide feedback to their peers as they do this. Now, it turns out that physicians are obviously quite competitive, and they do quite well when presented with data, but getting to that point can be tricky. Most people really today are only scratching the surface, and while preference items in orthopedics and cardiac are probably the most common examples of areas that are being tackled, there's a whole lot of things that can be done in terms of standard practices and processes to drive costs down, improve quality, and really prepare you for population health. On the practices and processes, it's on the one hand, it's about treating patients to empirical standards. It's also about identifying or creating the processes to properly identify and evaluate all patients that may benefit from training or procedure, or from evaluation and procedures, so that you drive the health of an overall population in a different way. And I've seen some systems be very innovative in their approach to that with significant impact. So that brings us to page 22. and our next quiz. So the question is, which of these areas presents the largest opportunity for margin improvement at your hospital? And it's the 5 areas we just talked through: revenue cycle, operations, labor productivity, materials management, and clinical variation. And by its very nature, the at your hospital means that there's probably not a right answer to this, but I will share with you in a moment what we typically see. All right, let's go ahead and close it. Interesting. It's fairly balanced with clinical variation coming out on top, followed by revenue cycle and labor productivity, followed pretty evenly by operations and materials management. So I'm going to discuss this in just a few minutes. So we've talked about each of the levers. The next stage, if you turn to page 23, is really all about creating a balanced portfolio of initiatives to go after this. The balanced portfolio of initiatives is really another way of talking about strategy. So this is your margin strategy. And if you look to page 24, a margin strategy really needs to start with a clear understanding of your performance. So on the one hand, you've now got an understanding of your gap by doing the modeling of, understanding what the future will hold for you. The second step in this is to understand your current performance. And really there's two takes on this. There's a top-level view, which is employing really simple is an important word here. Simple dashboards with benchmarks to understand where there are opportunities for improvement. And a simple dashboard like the one illustrated there really allows you to say, okay, overall, how are you doing? And by each of the key levers, what is your performance relative to peers and potentially to competitors in your market if that data is available. And that allows you to get a sense for the scale of the opportunity. The tricky part really here is using a top-level analysis like this to get to the scale of the opportunity. Because low performance in revenue cycle does not equal the same opportunity as low performance in labor, for example. The second view of this is to take a detailed assessment. And this is a much more rigorous effort aimed at exploring not just where the opportunity is, but in defining what the specific issues that you want to go after are and how big the opportunity is for those. This allows you essentially to build a plan to close the financial gap. There's lots of different options of how to build one of these assessments. They can be time limited, that is, let's just review everything in the next 4 months, or they can be ongoing, cycling through different topics. They can be cross-functional, meaning that all topics are covered in a single period, or they can focus in on the 1 or 2 topic areas that are really driving most of the performance. And finally, they can be budget or project-based, meaning that either it's something that you tie into your budget process, or it's something that you do one-off. How you structure this is important, but it's also dependent on who you are and how and where your opportunities are concentrated. There's some benefits to doing them all together, and there's some benefits to looking across the board. Because it really allows leadership to align as a group on the top priorities for the system overall, rather than having a functional view where everyone thinks of their own area as having a set of priorities, but never actually creating an overall picture of the focus for the organization. If you turn to page 25, what I present here is the opportunity areas that we tend to find as we work with our clients. These are typical ranges that we've seen. The interesting thing is that revenue cycle, operations, and labor productivity actually end up all in about the same range, about 2 to 5%. The operations is the one lever that folks on the in the poll suggested might be lower. And in fact, we see a tremendous amount of opportunity in this area still. In the OR, in the ED, in the bed assignment process, and discharging processes, all of which still leave much room and opportunity on the table, and can all be tied to real dollars. As you suspected, materials management tends to be lower. There's some opportunities across the board there, but they tend to vary significantly by facility, and they tend to be focused in one or two areas by facility, and therefore they tend to be smaller overall. Clinical variation is an area that came out as the most popular answer in the sheet, and I actually think that's correct. What we highlight here are some of the most conservative opportunities and the most easily identifiable opportunities, but actually the most potential overall is going to be in this area, because it's much more about reducing the cost of supplies in cardiac, ortho, and septicemia. It's about driving to overall quality and creating the performance that allows you to succeed in population health. As we go through this for a client, the total impact is about 6 to 12% per client, % of revenues. Obviously, that's not summative because not every client performs at either extreme. But for a typical client, this ends up being, for a 250-bed hospital, there's about $15 to $30 million of opportunity. If you were to convert that first chart I showed you, modeling the impact, to a 250-bed hospital, that gap for that, given that scenario in that market, would be about $35 to $40 million. So you can close about half to three-quarters of the gap with margins approaches alone. And then the remainder of this gap for this hospital would need to be closed looking at growth opportunities and partnerships. Page 26 shows how, one approach to bringing all of these different initiatives together into a single plan. Typically, we have conversations with clients that focus on selecting a subset of initiatives that will be the focus for the top team. And these should be balanced between near-term and long-term opportunities. They should be balanced between things that are more or less challenging, and they should be typically for the top team focus on those things that are the most impactful. So in this example, you may focus on opportunities 1, 7, and 5 for the top team. These are purely illustrative, but conceptually that's the approach. The reason that I've highlighted that doing all of the an assessment across the board all at once is because this allows you to balance and identify initiatives across the board in one time. It allows the entire leadership team to see what that balanced set of initiatives looks like altogether, and to pursue those all on the same pace. So let me turn to page 27, which is the final portion of the presentation, summarizing what we've covered. So I think there's a few key messages that come out of what we just went through. One is the next 12 to 18 months are really critical. A lot of hospitals have been slow off the mark waiting for reform to settle out in the Supreme Court decision. The fact is that change is coming, and even with the election and the potential for revoke parts of the reform legislation, some of these changes are likely to stick in the industry, and it's important to understand what are the long-term trends and what will be the impact of those on your facility. At the same time, it's essential to take a look at margins, understand your current performance and opportunities, and double down on productivity and cost control in those areas. So use that gap to create a burning platform for change. Prioritize your top team on the areas that are going to be the most important for you, and then track improvements very rigorously and intervene early when you see things not coming along. All of those things are really concentrated on the margins side. The next step beyond that is to look at emerging patient segments and target growth to profitable and fast-growing segments. This is about identifying and selecting those areas that are important to you in your local market and sharpening your value proposition, which may mean changing your business model in some cases. And this is where hospitals are getting into pharmacies and clinics and providing clinics with employers and things like that. The final area, which is partner and innovate, and this is something where in some cases folks are going full steam ahead and in others they're being a little bit more hesitant, and that's probably an okay strategy. But this is about looking at partnerships with payers and providers and distributors and suppliers to allow you to build more scale in the market and prepare you for population health management. So those are the core messages. Let me pause here and open it up for questions.
Thank you, Dr. Flyckt. That was a great presentation. We will now begin the Q&A portion of the program. As a reminder to all attendees, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have, and will follow up on questions he does not have the opportunity to address. We do have a first question here, Dr. Flyckt. How can my hospital be competent in modeling future? Seems like there's a lot of uncertainty.
Yeah, so thank you. So I think the truth is there is a lot of uncertainty, and the approach is really one of building up your analysis by component. So and understanding the uncertainty of each of those components in turn. So there are some things that are more certain and less certain within that set. So demographics and demographic shifts are more certain. The economic environment within your market is more certain. Less certain, practice pattern changes are more certain. The specifics of healthcare reform, while somewhat uncertain, are also increasingly well understood and can be layered into your model. So each of those components can be understood quite well. The other piece that's important to modeling this is making sure that you have buy-in from the stakeholders that are going to use this analysis, and to ensure that you have trust. So there are a number of assumptions that need to go into this model, and those assumptions are not certain. And so making sure that all of the folks that are affected by the outcome are going to have a voice to be heard and can discuss and understand the ranges of assumptions that are reasonable means that at the end of the day, you'll have a model that you can be both comfortable with the projection that you're making, and comfortable knowing that people understand and believe.
Okay, thank you. Next question. How long does it take to do a full assessment? How many resources would it take to run without external support?
So we typically run these assessments for about 4 to 6 months, but it depends on obviously the scope of the number of areas that you're covering, and particular timelines. So while a typical engagement might be 4 to 6 months, for a hospital that has a deadline, a budget, you can do these at different levels of depth in anything from probably 6 to 10 weeks across the board. But this is something that depends on which areas are important to you, and if you want to run it in multiple areas simultaneously. For the analysis and support of, this is something that, if run internally, would take probably an FTE or 2 in each area, with the addition of analytical resources. So if a hospital has an analytics support group or a strategy group that can help facilitate it, that takes some pressure off the front line or each department. But this is something that could easily involve 10 to 20 people for an extended period of time.
Okay, great. Next question, how hard is it to capture opportunities in each of these areas? Which areas are harder to go after?
So that's a good question. The short answer is that the more contained areas tend to be simpler. So revenue cycle, not that it's easy, and purchasing, not that that's easy, tend to be more easily capturable than some of the other areas. The labor is, it can be really challenging. Operations, for the reasons that we already discussed, can be very challenging. Probably the most difficult role for hospitals to pursue at this point is the physician clinical variation side of things, because it's an area that not very, many are not very well experienced in, and physicians are not yet, many of them don't yet expect to be accountable for these things to a hospital. So in short, revenue cycle and PSM are on the easier end, and clinical variation is probably the hardest.
Okay, great, thank you. This next question is kind of a long question. It's a question from a multi-hospital system. When executing a Medicare break-even strategy through materials management, and in parentheses she has implant standardization, etc., and reduction in physician variation, is it best to approach this at a system level or facility level?
Once you get down to implant standardization and the really clinical side of things, it's the primary person who should be driving it is your CMO, if you have one. So a senior clinician that can speak the language of other physicians and do so with the respect of their peers. I've seen that happen in both ways, and both ways can be effective, but many systems don't have that type of a physician in that kind of a leadership role. So that's really what's going to determine where you should make that play. Both can be effective. If you do have someone driving it centrally, a physician driving this centrally, it's important that they have lieutenants or folks at each of the sites that are going to be able to provide that same type of visible role modeling and support. And without that, it's going to be very difficult to get through.
Okay, great, thank you. This next question, when partnering, what seems to be the best method of partnering? Physicians' employment versus affiliations, hospitals purchase versus affiliations?
That's probably too complex of a question to answer here. I mean, the short answer, it depends, and it depends on from everything from the service line that's involved to the market that you're in to the particular physicians that you're engaged with. There really, I don't think, is a one-off-the-fits-all answer to that question.
Thank you very much. This next question, it seems that hospitals routinely are extremely slow in making decisions. Some people suggest they are even slower than government. Are there hospitals? Are there hospitals? Oh, excuse me. Hold on just a minute. Are there hospitals that actually move quickly? If so, what helps them able to move more quickly?
There are hospitals that move at different rates. There's a couple of things that the quicker moving hospitals tend to do. One is they tend to have a very decision-oriented strategic planning process, so that the big decisions that everyone needs to get involved with gets to decisions very quickly. So that means not being consensus-driven, which some places are, and it means having very clear lines of responsibility and decision rights, which many places lack. The other piece is not making all of your decisions through the budget cycle. It's very important. I've seen some of the slowest moving systems that I've seen are those that try to make every decision in a 2-month period prior to their budget, and then stick to that for the rest of the year. And especially hospitals that are part of larger systems can get completely bogged down in that process and end up putting decisions off until a certain time of year and then cycling back and forth between the system and the individual site to try and get resolution on something. And that can, avoiding that like the plague is probably one of the, the best things that you can do. But allowing people to make a subset of decisions independently and then having a strategic planning process that gets to decisions quickly is important, and then having the flexibility to make smaller decisions throughout the year. The type of prioritization all at once that I've described can be a very effective mechanism because it allows every member of the team to see the same information at the same time.
Okay, great. Thank you very much. Again, I want to remind attendees that in order to ask questions, just please submit them into your control panel that says enter a question for staff and clicking send. I'm looking to see if we have any more questions here. And it doesn't look like we do. So Dr. Flyckt, if there's any last words that you would want to let everyone know before we end the presentation today, that'd be great.
No, thank you very much for giving me the time to speak. And if you have more questions after the presentation, my contact information is listed on the front of the presentation.
Yes, if all the attendees would direct their attention to the last slide that's up, that's a great way to be able to contact Dr. Flyckt if you have further questions that you want to speak about. I want to thank everyone today for joining us. We look forward to having you again in future webinars. This concludes today's program, and have a wonderful afternoon.